Thank you. We will now go to the ranking member, Mr. DeSaulnier, for his questions.
Thank you, Mr. Chairman. I want to follow up on the Chairman Fox's questions about the prohibition on gag rules. And so, starting with Ms. Moynihan and then Dr. Sackliffe, if we required a plan's data to be treated as a plan asset under ERISTA, how might that help with getting the information that Dr. Fox was talking about?
That would effectively kind of flip the framework we currently have on its head. So rather than the PBMs and TPAs kind of owning the data and setting the terms by which an employer can access it, it would say this is the employer's data, and the employer can then set terms, or Congress could set terms under which the TPAs or PBMs could be using that. And there are certain important functions that they would perform. So we would want to make sure that would still happen in some sets. But the employer, that would be their data, and they could have access to it. The one thing I'd want to make sure is that there are appropriate privacy protections to protect the plan members whose health information would be accessible.
Doctor, any comments?
Yeah, so, in addition to the gag clause where you say we're going to remove this, there's, it's one thing to say the gag clauses are gone. It's another thing, there's a lot of stalling that happens in getting the data to the employer. You can make the request, but they may give you the wrong data. It may take 18 months to get the data. So I would really encourage you to think about a time frame by which they have to give the data back. In Indiana, we put 15 business days in statute. Also, again, with the audits, we have a law now that says 85 to 100% of rebates have to go to patients or employers. How do we know that 100% or 85% or any percent is actually getting, we have to get it. We have to have those audits at the drug level, not in aggregate. And I think what would be perhaps most transformational is with the Transparency and Coverage Act, all the insurance information, all the PBM drug pricing information, as these insurance companies have to put those prices on their machine-readable files on their own websites, the hospitals have to put it on their own websites, they should all send a copy to you. You could put it in a master database. You would be able to see how prices compare when policies change, monitor it, look for compliance, and also give the public access and researchers access. That way we would be all making evidence-based decisions in a, in a policy manner, in a purchasing manner. As you mentioned, employers don't have a lot of resources to do all this deep dive data analysis. So the federal government, just getting a copy of these machine-readable files could really go a long way to help them.
Thank you. Ms. Tripoli, we talk a little bit more about hospital facility fees and the cost of hospitals. It's interesting listening to this, having many years ago, 20 plus years ago, being on the governing body of a public hospital and clinics in an area in the San Francisco Bay Area, in the East Bay, where Kaiser is very closed system is dominant. And we were trying to move the high cost of what we call the aircraft carrier, the hospital, and so was Kaiser, and so was Sutter, and so was Anthem's affiliated, into primary care and into community-based clinics. Now, I'm listening to this testimony and reading, and the hospitals seem to have changed that model to sort of capture even the lower cost at a higher cost reimbursement. Is that accurate?
That is accurate, and I would completely agree. I think we want to make sure, as was mentioned earlier, that services are provided in the most safe and effective location possible, but what we're seeing is a complete shift to outpatient care where it's higher priced, higher cost services to take advantage of a higher reimbursement. So,
Ms. Moynihan, as a consumer, personally as a consumer, as a survivor of cancer and non-curable cancer, trying to navigate this is basically just giving up to a certain degree and trusting your primary care doctor. Fortunately, I have a really good one, but he has to advocate and figure out where are we sending you. And to get started on the pharmaceutical industry and going to Walgreens as opposed to a personal local pharmacy is just a hugely different world. But sticking to just the access to the facility, what does this mean for the consumer? I know my perspective, you just have to really count on your primary care physician.
Very much so, and I think it really means that consumers are going to be paying a lot more because so many physician practices are now being purchased by hospitals and large health systems, and they'll, it's not really necessarily up to the physician You know, but when they go and they see you at this location that's owned by the health system is going to tack on a bill. And that bill, how it's being processed under your insurance, will often mean you are paying a lot more when you would go to see your physician. You might just have a copay, but now you have this additional hospital bill, and that might be, you know, a co-insurance charge, or you're paying for all of it under your deductible. So it's a lot more money just to go to your doctor.
Yeah, it's awful for the consumer. Thank you, Mr. Chairman. I just want to mention my oncologist in case he's listening. I rely on him too. I yield back.